session. Today, Dr. Hengameh Raissy is going to be talking about clinical research and asthma. And if we could just go around, and if you've signed in, please tell us who you are and where you're from so we can make sure that we have you recorded so you get your CMA credits.
Nicole Vega, Joanna Stagner, and Deborah Roberts from After Hours Pediatrics.
Wonderful, thank you.
Thank you.
And Susan Jenks from Albuquerque Public Schools, school nurse.
Hi, Susan, thank you.
Thank you.
Oh.
Michael Lance, ABQ Health Partners.
Thank you. Is that everybody? Okay, well, I guess we'll go ahead and get started.
Just you and me.
Yeah. In the conference room, it's just myself, Francine Caffey, and Hengameh Raissy. So we have a small group in the conference room today.
And we are both from Pediatric Pulmonary at UNM.
So I'll go ahead and let Dr. Raissy get started.
Hello, everybody. Today I'm going to talk to you about some of the clinical research that our division at UNM has been involved with. Most of these trials are already published, and I'm going to tell you about some of the trials that we have ongoing. And again, as I mentioned, most of them are already published, so I'm going to have a quick overview of the result of those studies. Go next, or
about a right arrow.
I was trying to use with the mouse. Okay.
And just a quick housekeeping, this is Kevin Whirling, Systems Analyst here at Envision. And star pound is what you use to mute your line in case it gets noisy out there. If it does get noisy and I don't see that you've muted, I can mute you. And you'll be notified that you are. And just hit star pound if you want to join back into the discussion.
Okay. So the next slide is about disclosure of any conflict of interest, which actually I have disclosed one, and that is the fact that I'm the co-author in these publications and studies that I am discussing with you. I'm also the principal investigator for these network trials here at Albuquerque site. All of them are funded by NHLBI, so financially, there is no conflict of interest. Okay. Great. So I think we can get started. So first thing I want to mention, the first slide that I have is actually about Clinical and Translational Research Center, which is the center that we use to conduct all these trials at UNM. The award to have this center came to us actually in 2010, which was a continuation to GCRC, General Clinical Research Center, that we had at UNM. But the new award has one mission, and that is to translate research from basic science research to clinical research and to community. And all with one goal: to improve human health and translation of scientific discoveries into practical applications. And I hope what we are doing here at Envision as part of our pediatric pulmonary mission is to translate the research that's being done in clinical practice. Why we are doing this? Because we think we can actually speed up the process when it comes to health outcomes. As you can see in this slide, it's nothing a few stem cells and another 75 years of research cannot fix. We are hoping we can actually make this less than 75 years. So with that, I'm going to start talking about one of our big accomplishments at UNM, being part of the CAMP trials. I'm pretty sure you all have heard about this at this point from CAMP trials, because all of us mentioned that in every single presentation. CAMP was a childhood asthma management program trial, which is the longest and largest asthma trial that has ever been done. And we were one of the 9 centers. And for the first part of my talk, I'm going to focus on this part of the trial, actually the treatment phase of the trial. That was when we enrolled more than 1,000 patients from 9 centers. 110 of these patients came from Albuquerque site, from UNM site. And these patients were randomly assigned to budesonide, placebo, or nedocromil. Budesonide was 200 microgram. The dose of budesonide being used 200 microgram BID. Nedocromil was 8 milligram BID and placebo. The objective of CAMP trial was to learn about the long-term effect of inhaled corticosteroids on management of asthma in pediatric patients. So patients 5 to 13 years of age were recruited over less than 2 years and were followed for 4 to 6 years. These patients had 3 visits per year, and again they were randomized to these treatment phases, and we monitored them very closely. They had to fill out their diary cards every day during the 4 to 6 years. So we had very precise information about how they are doing and how is their asthma is controlled. Again, as I mentioned, randomization was to be budesonide 200 microgram twice daily, nedocromil 8 milligram twice daily, and placebo. Patients also had albuterol and prednisone in hand in case of emergency. What we learned from CAMP trial was that although there was no difference in the lung function of these patients in this treatment phase, inhaled corticosteroids significantly improved asthma control in these patients. You can actually see that this CAMP result from this early phase has been cited by more than 100 articles, because pretty much anybody that does any study with inhaled corticosteroids cites this study to show how inhaled corticosteroid can improve asthma control. As I have listed a few outcomes here, is that you can see that inhaled corticosteroids, budesonide, decreased airway hyperresponsiveness as it was measured by metacalling challenge. Patients on inhaled corticosteroids had 43% fewer hospitalization, 45% fewer urgent care visits, 43% less prednisone use, less rescue albuterol use, fewer symptoms, and they had more episode-free days. These are exactly the parameters that we use to define asthma control. And as you know, and as guideline recommends, inhaled corticosteroids are more effective than any other agents that we have on when it comes to all asthma outcome measures. And then we also have other alternatives such as cromolyn, lipotropin receptor antagonist, nedocromil, and theophylline. But as you know, most of these are not available anymore in the market. And for some of them, we don't even know if they are a better choice for our patients or not. So what seems to be an issue when it comes to inhaled corticosteroids? What happened at the end of treatment phase is we learned about the effect of inhaled corticosteroids on growth. So again, I'm talking about the early phase of CAMP trials for that duration of 4 to 6 years. What we learned was that at the end of their trials, patients on inhaled corticosteroids were 1.1 centimeter shorter than the other group on nedocromil or placebo. So what we said at that point was that, okay, inhaled corticosteroids can have some effect on the growth, but the effect is transient, and it caused a transient reduction in growth. Why did we conclude that? Because until then, all the data available pointed out that the growth is going to be fine at the time that these kids reach to their adulthood height. Why did we conclude that? Because if you look at this slide, that sometimes can be confusing, is the first year of the treatment phase, the rate of the growth was less in budesonide group. So the rate was actually fine at the end of the trial compared to all the trials. So the rate of the growth became the same at the end of treatment phase. The difference in the first year, because the growth slower in budesonide, led to that decrease of 1.1 centimeter at the end of the trial. So we thought, as literature suggested at that point, that there will be a catch-up growth at some point. Either they're going to grow longer, these kids, or they're going to have a catch-up growth before they reach to their adulthood heights. So that was the conclusion of the study with regard to side effect of inhaled corticosteroids and the effect on height. We called it a transient reduction in growth. So what we did after that, we followed these patients for 13 years. We got funding from NHLBI and NIH to follow these patients until their adulthood without providing them any medication. So during follow-up phase, these patients were managed by their primary care physician. What we did, we saw them 1 to 4 times every year, and we collected data from them, what medications they're taking, how many bursts of prednisone. We measured their height and weight. We did a spirometry, and we also did metacolling challenge. Again, we want to understand what happens to them when they grow up, simply, and we want to know what was the effect of that treatment phase that we provided them for 4 to 6 years. So what is the long-term effect of inhaled corticosteroids in children when they have grown up and they have become adults? So what we learned at that point was that there is no catch-up growth. So when we ended camp follow-up trials, all the patients were not kids anymore, and they were in their adulthood. So, and they have reached their maximum height, and they did stay shorter. So as you can see in this graph, budesonide compared to placebo, kids were these adults now were 1.2 centimeters shorter. So there was no catch-up growth. The effect was actually more pronounced in females who were 1.8 centimeters shorter. The guys were only 0.8 centimeters shorter. So all I can say about females is that thanks to high heels, we don't have to be worried about too much. But the overall effect was 1.2 centimeter. So what we used to call a transient reduction, now we know it is actually a suppression of growth. But what we also need to keep in mind is the effect of inhaled corticosteroids on management of asthma overall. So if you put things in perspective and you look at pros and cons, being 1.2 centimeters shorter, it's really nothing compared to control of asthma that we can provide for these patients. So CAMP was as I mentioned, was the longest and largest trial that has looked at this effect of height and inhaled corticosteroids in a prospective trial, and that was the only time that this was done, and that's why this cohort was significant when it comes to providing information about the use of inhaled corticosteroids in children. So after we finished that study, we had opportunity to participate in 2 Asthma Network trials. The first one is CARE, which is Childhood Asthma Research and Education. The center was funded by NHLBI to do clinical research only in pediatrics, and was funded in 1999, then again in 2004. We joined the center in 2007, and we were able to participate in 2 clinical trials that I'm going to go over those with you. In 2009, when CARE Network terminated, we were able to apply and get funded to be one of the AsthmaNet centers, and I'm going to mention about ongoing studies with AsthmaNet Center at UNM. So the first study that we participated in CARE Network trial is called TREXA. TREXA stands for Treating Children to Prevent Exacerbation of Asthma. The result of TREXA was actually published in The Lancet in 2011. In this study, we enrolled patients aged 6 to 17 years old. The objective was, if we have patients who are controlled and they have mild asthma, what is the next best step? What we know is that these kids are going to be controlled and we are still telling them to use their inhaled corticosteroids every day. And I don't know about your patient, but in our patient population, they won't. They don't have symptoms. They stop taking their medication. So the whole the objective of this study is that how can we manage these patients? How can we step down from mild asthma? And there is no recommendation in the guideline. So for this study, 843 patients were enrolled, and if they demonstrated control in 2 months, meaning they don't have any symptoms more than twice per week, then they were randomly assigned to 4 arms of the treatments. The first arm, they continued their daily use of inhaled corticosteroids, and every time they had symptoms, they used a combination of inhaled corticosteroids and albuterol. Second arm, they continued their low-dose inhaled corticosteroids, and they used albuterol as needed. It is just like how we are managing kids right now. Third arm, they did not use anything every day. So they were using actually placebo inhalers every day. Every time they had symptoms, they used a combination of inhaled corticosteroids and albuterol. So every time they used 2 puffs of albuterol, they also used 2 puffs of their inhaled corticosteroids. Of course, they didn't know what they're using because it was all double dummy, meaning they had 2 inhalers to be used as a rescue medication. And the last arm of the study, they did not have anything daily, and they only used albuterol every time they had symptoms. So 288 patients made it to the randomization phase and continued this study. These patients were followed for 1 year. And what we learned is, if we look at the hazard ratio of asthma exacerbation, and other word, the probability of having the first exacerbation in this trial, only those patients who were using daily inhaled corticosteroids showed a statistically significant difference compared to placebo. So once again, we are showing that inhaled corticosteroids, when it is used daily, can prevent exacerbation and can control asthma. When we look at the other 2 arms, the arm that was using daily inhaled corticosteroids plus combination of rescue medication, or the arm that they were using placebo every day plus combination of rescue medication during symptoms, we did not see a difference in asthma exacerbation compared to placebo. So just to change the numbers a little bit here and show you what was the risk of exacerbation, for those patients that they were using daily inhaled corticosteroids, the rate of exacerbation at the end of the probability of having exacerbation at the end of the trial was 28%. In the placebo group, it was 49%. So how can we translate or explain that in our clinical practice? These are our patients who are controlled. And because they are controlled, they don't have any symptoms, they're going to stop taking their medication. And there is a 50% chance of these patients having asthma exacerbation at the end of the year. And if we look at the combination of albuterol and inhaled corticosteroids, the risk of exacerbation was 35%. Another way of looking at the data is if we look at 2 exacerbations in 6 months, you can see that in the patients who were using daily inhaled corticosteroids, the rate of exacerbation was 2.8%, which was statistically significant compared to placebo. And for those that they were using albuterol plus inhaled corticosteroids to manage their symptoms, the rate was 85%. Compared to placebo, that was 23%. So if you look at the data this way, we could actually see a difference in the group compared to placebo, both those that were using inhaled corticosteroids every day and those that they did not have any daily medication, but they used albuterol and inhaled corticosteroids in combination for prevention of symptoms. So what we're concerned about, as always, with inhaled corticosteroid is linear growth, right? So if you look at this graph, it demonstrates that for patients that they were using everyday inhaled corticosteroids, the rate of growth, again, was less in that first year, and patients were 1.1 centimeters shorter compared to those patients that they were not on daily controlled medications, and they were using only albuterol or albuterol plus inhaled corticosteroids for management of their symptoms. So what we concluded in this study was that discontinuation of inhaled corticosteroid causes an unacceptable increase in exacerbation in children with well-controlled mild persistent asthma. As I showed you, there was a 50% chance that these patients would exacerbate in the next year. Daily inhaled corticosteroid is the most effective treatment for prevention of exacerbations, and even adding a rescue inhaled corticosteroids on top of that did not provide any additional benefits. However, if we have patients that they are controlled and they need to step down, and we know these patients are not going to continue their medications, rescue inhaled corticosteroids with albuterol demonstrates benefits over albuterol alone, and avoids daily inhaled corticosteroid administration and its growth effect. But please, please, please do keep this in mind, that we have to look at the patient population when we consider this kind of a strategy for patients management. We monitor these patients during the screening phase very closely to make sure their asthma is actually controlled. So this is a step down. This strategy does not apply to the patients that they have mild symptoms. So we cannot just start them on this rescue inhaled corticosteroids and albuterol right away. This is a step down after we confirm that these patients are controlled. So the next trial that we conducted in Care Network is called the MIST, and the result of this was published in New England Journal of Medicine. This is another way of actually evaluating intermittent therapy in patients, but this group of patients were actually different. In MIST, we were looking at maintenance versus intermittent inhaled steroids in wheezing toddlers. So patients that we had recruited for these studies were 12 to 59 years old. They had recurrent wheezing, they had a positive asthma predictive index, and they had to have at least one exacerbation in the prior year, because previously literature had shown us that only those patients may benefit from use of everyday inhaled corticosteroids. So again, 278 patients were enrolled in this study, and there were two arms to this study. The first arm, they were using low-dose inhaled corticosteroids, which was defined as 0.5 milligram of Pulmicort every day, and they used placebo inhaled corticosteroids during their episodes, which I'm going to talk about what I mean by episodes. The other group, they did not use any medications every day. They were using placebo medications, and during their upper respiratory tract illness episodes, they used high dose of inhaled corticosteroids, Pulmicort 1 milligram BID for 7 days. So that was again another way to evaluate the usefulness of this intermittent therapy. And our hypothesis was that daily inhaled corticosteroid is going to be superior to this intermittent management of just upper respiratory tract illness. The trick about, or the significance of this study was that mom had to recognize the early signs of upper respiratory tract infection and or illness, and they had to start treatment before it becomes a full exacerbation. So that was actually very, very difficult to work with parents. So we had them call us if they had any question at any point regarding when to start the therapy. And what we learned about this study was that a daily low-dose regimen of budesonide was not superior to an intermittent high-dose regimen in reducing asthma exacerbations. And daily administration led to greater exposure to the drug at first year. So for MIST, again, when we looked at all the outcomes, time to first exacerbation or episodes of wheezing use of prednisone, again, there was absolutely no difference between these two groups. So that was again one of the first studies that shows intermittent use of inhaled corticosteroids might be beneficial in this group of patients. And again, the age group was 12 to 59. These are the toddlers that we call them recurrent wheezers. We do not say these kids have asthma. Another thing that we are still continuing to analyze and evaluate is at every single episode that they had for these upper respiratory illnesses, we collected mucus, nasal mucus. Simply, mom had to have the kid blow in a Ziploc and freeze it and bring it to us so we can do the evaluation, because we want to learn if some of this episode, depending on the nature of them and what is the cause of the episode, might respond better to inhaled corticosteroids compared to others. So that publication hopefully will be out soon. So these were the two trials that we had with Care Network. The next two trials that I'm going to mention is what we are doing right now with AsthmaNet. And again, it is simply, they are based on the previous work on toddlers. So the first study that I'm going to talk to you about is April Ocelot. Again, for this study, we have completed enrollment 600 children 12 to 71 months old. So April stands for azithromycin for prevention, development of upper respiratory tract illness into lower respiratory tract symptoms in children. I'm sorry, and the next one, oh, that was just repeated. And Ocelot was actually prevention of management of asthma exacerbation. So the way that this works is that, again, as soon as kids or toddlers, they start having symptoms, mom is going to start the April kit. What April kit is actually azithromycin. As I'm sure you all have heard, azithromycin may have some anti-inflammatory effect in this patient population. There are a lot of physicians who actually prescribe azithromycin as a first sign of symptoms, of respiratory symptoms, because they're thinking if it doesn't cover the bacteria, it is going to cover the inflammation that is occurring at that point. So for this study, as soon as patients have symptoms, moms start using azithromycin, and they use a 12 milligram per kilogram dose once a day for 5 days. At the same time, for the first 48 hours, they use albuterol every 6 hours. If patients get better, great. If not, they're going to call us, and that is when we start the Ocelot's portion of the study. In the Ocelot, we randomize patients to prednisolone or placebo. Because, believe it or not, there isn't enough evidence that prednisolone actually, or steroids bursts, would work for patients, for toddlers at age of 12 to 71. And again, that is because we still do not understand fully what is causing the nature of wheezing in this age group, and we were trying to understand who would respond to prednisone burst and who does not. And again, for all of these episodes, we are collecting nasal samples to do the culture and to understand the nature of this more. So hopefully one of these days, maybe next year, I'll be sitting here and presenting the result of this study to you guys. The next study that we have just started and we are enrolling is going to be in the same group of toddlers, 12 to 59 years old. What we are doing here, again, sort of kind of is based on MIST. We are comparing in a crossover design the effect of daily inhaled corticosteroids to montelukast to as needed combination of inhaled corticosteroids and short-acting beta agonist albuterol for the symptoms. For this study, we are randomizing patients who have mild, again, I don't want to call it asthma, but they do not have frequent everyday symptoms. Because if they have everyday symptoms, we know we have to put them on inhaled corticosteroids every day. That's the best thing to work. These are the toddlers that they have symptoms less than 2 times per week. That's why we have a very long actually run-in period to make sure they do not meet the qualification to be on everyday inhaled corticosteroids, but they still have symptoms. How can we manage these toddlers? Again, each patient is going to be on one of the arms for 16 weeks, and they're going to be crossed over to the other arm. The duration of this study, again, is going to be 1 year, and we are looking at asthma exacerbation. And we are also looking at some genetic parameters to see if we can figure out who may respond better to what kind of the treatment. For this study, again, as I mentioned, we are enrolling patients, and we do need to have about 294 patients before we close the enrollment. So these were summaries of our active trials. And with that, I'm going to open to questions about any of these trials. And also, if you need a copy of any of MIST, TREXA, or any of the CAMP projects, I'll be more than happy to forward this to you, or maybe put them on at Envision website. Any questions?
I have a question. So for the now I've got them all confused. The TREXA study, that's where they had the 4 different arms.
Correct.
Right? Was the dose of the daily inhaled steroid the same as the dose of the rescue?
Yes.
Okay.
It was for TREXA, we were using beclomethasone QR, and the dose for daily medication was 1 puff BID of QR, 40 microgram per puff.
Okay.
And if they were using albuterol, if they used 2 puffs of albuterol, they also used 2 puffs, which was 40 microgram per puff of QR. If they used 4 puffs of albuterol, they also used 4 puffs of the other inhaler.
Okay.
So they had 2 rescue inhalers.
Mm-hmm.
So they had to do same number of puffs from each of them.
Interesting.
But at the end of this study, when you look at the cumulative dose of inhaled corticosteroids that they have been exposed to, of course, the rescue group was exposed about 1.4 milligram less to inhaled corticosteroid, to the steroid overall.
Okay, today.
And that explains why we saw a difference in their growth, right?
Mm-hmm.
Less steroid, less effect.
And were there any sort of parameters in either the TREXA or the MIST study in looking at, because as you had mentioned, especially in those younger age groups, sometimes it's difficult to say, is this, the term I use is viral associated wheezing or viral associated asthma versus, you know, how many episodes is too much, and when might you benefit from being on a daily steroid?
Yes, we did have a definition for treatment failure.
Okay.
For every single study we do. For TREXA, if they had 2 exacerbations, they were done. That was considered a treatment failure, even if they hadn't met 1 year duration of the study. The same. So for every study we have these definitions. For the same thing with MIST, if they had 2 episodes in 6 months, they were terminated from the study, because at that point they met the requirement to be on everyday inhaled corticosteroids.
So really, as far as the toddler study, the TREXA study, these would be kids who maybe have 1 or 2...
TREXA was 7 to 12 years old.
The MIST.
MIST, yes.
All these acronyms get very confusing. In the MIST study then, so intermittent inhaled steroids might be helpful in a child who maybe has 1 or 2 colds a year where they actually have wheezing.
Yes.
But if they have more episodes than about 2 in a season, then you may want to consider a daily inhaled steroid.
Correct.
Okay.
You always have to pay attention to inclusion criteria for these trials. For MIST, we want a patient to have at least 1 asthma exacerbation, which was defined as urgent care visit or prednisone use and scheduled visit to the doctors, and they should have been positive for asthma predictive index.
Okay.
So these were the patients who were bred in. If they had more than 3 exacerbations the previous year, they were not enrolled in the study. Again, these are intermittent asthma.
It might be kind of a hard group to even pick on to know to start intermittent inhaled steroids on.
Correct.
Depending on where they get their care.
Correct. So again, when we choose patients for asthma predictive index, we would expect them to have asthma as they get older. The risk of having at least 1 exacerbation would put them in the intermittent category, but if they had more than 3 exacerbations, that was definitely out. those patients benefit from inhaled corticosteroids every day in order to prevent those exacerbations.
Does anybody else have any questions? I have one more question.
Okay.
So since the CAMP study, there have been quite a number of new inhaled corticosteroids that have come out. And some of them are reported to be, they're a prodrug which gets actually converted once it gets into the lungs. Have there been any comparisons to see if if the effect of on the height is different, or there's still too new to tell?
It is too new to tell. In CAMP, budesonide was used, and the reason is in '93 when they started the study, budesonide was one of the available inhaled corticosteroids. And as I'm learning in these network trials is that when we design the proposals, then we actually try to say, okay, which drug company wants to donate the medication? Because as you see, we have to enroll something between 200 to 300 patients, and we provide them medication for the duration of 1 year. So that adds up to be a lot of money. So we actually look for pharmaceutical companies who would like to collaborate and donate medication. Mm-hmm. So AstraZeneca was the one that donated medication during CAMP, and that's why budesonide was used. So I actually wrote an editorial to explain that these kids were on budesonide for 4 to 6 years. The average was actually 4.5 years. So this is not how we do manage kids actually in the clinics, right? Because we see them frequently, we see them every 3 to 6 months, we increase or decrease their dose. Sometimes summertime, if that is a good time for them, we actually take them off of the medication, we put them back on the medication when they start school to decrease exposure to inhaled corticosteroids. So what CAMP did actually confirmed the effect on height, and also we learned that there is no catch-up when it happens. Mm-hmm. Now we have to look at the new inhaled corticosteroids and new strategies. Mm-hmm. That's why we have these intermittent strategies to see if we can actually manage exacerbations without exposing kids to unnecessary doses of inhaled corticosteroids. And yes, there are new medications, and they have different therapeutic indexes that might be beneficial, but there hasn't been long trials to actually look at the effect of them.
And it seemed like a lot of, in both of the trials, the MIST and TREXA trials, with adding the inhaled steroid for rescue, there wasn't an arm just doing prednisone and albuterol rescue.
No.
Which I would also kind of wonder about, because by the time depending on the dose of the inhaled steroid, it might be more cost effective to give the oral prednisone.
Correct. But no, we have not done that. That would be very cost effective because prednisone is very cheap. But again, with CAMP trials, we show that when patients use more than 2 bursts of prednisone, it does have some effect on their HPA axis and on their bones. So because of that, that is usually not an option. Another study that we are working on with AsthmaNet is that, again, I know some physicians would like to do that to increase the dose of inhaled corticosteroids as soon as patients are in yellow zone, as we're saying it. So we are actually trying to do a large trial to see if that can be effective, and if you're going to increase the dose of inhaled corticosteroids, should we increase it twice or quadruplate the amount of inhaled corticosteroids? What is actually the right dose? But again, we are trying to avoid prednisone because we do know of the systemic effect.
Did anybody have any questions? Okay.
Hi, this is Shirley Murphy. I have a question.
Oh, yeah.
Hi, that was an excellent presentation. I have a question. As you know, I volunteer in the Kingdom of Bhutan and will be going back and probably be calling in with patients. And I heard all the patients you advised me about last year are doing well today. So it's a developing country, and they only have one corticosteroid, and that's beclomethasone. And I wanted to ask you about and it's a meter dose inhaler, using that with a spacer and without a spacer, and from your experience and the trials, Francine and Hengameh, what do you advise? And they have a one-way valve high volume spacer there available.
Sure.
Well, basically, we recommend that everybody use a spacer with their inhalers. So, and part of the reason for that is it really helps to make sure that the medication is being hopefully delivered down into the lower airways and not the back of the mouth. I think even in adults, inhaler technique can be very difficult to get proper technique. And so we recommend spacers for everybody.
Yeah. Shirley, do you know if it's the HFA or CFC?
It's HFA.
It's HFA, okay. Great. Because again, betlamethasone HFA has less systemic absorption compared to CFC, because CFC betlamethasone was at the same level as triamcinolone, and they did have a lot of systemic absorption. So spacers were highly recommended. With HFA, the systemic absorption is less, but it is still recommended.
And I think we get into the problem always of carrying a spacer, and for all the time use. And I certainly used it in the younger children, but you're recommending it also in the older children as much as they can possibly use it.
We really do. Of course, if it comes down to taking the medication,
they don't have backpacks and
Yeah. So if someone has the correct technique of using an MDI, they can deliver the same amount of medication when they use a spacer. Okay. So when it comes to clinical effect, having a perfect technique does not make a difference when it comes to drug delivery, if you use a spacer or not. Right? But then it becomes a systemic absorption from oral cavity. And if they do not carry their spacer, one recommendation is to just rinse their mouth right after they use it.
Okay.
And that's definitely better than not taking the medicine.
And that is definitely better than not taking the medicine, yes.
I guess the other thing I worry about, because we see this in teenagers all the time who don't want to carry a spacer with their albuterol, is that when you're taking your albuterol, it's usually because you're having symptoms, and more than likely your technique is not going to be very good without a spacer. So that's the other thing that I worry about, and kind of another reason why I try and encourage it as much as possible.
Good point. And the technique that you use now, I've seen several, lots of different techniques. The technique with a large volume spacer with a one-way valve is what do you currently recommend?
Okay.
So,
take one puff and then 10 breaths and.
One puff, in a young child 6 breaths, or in an older child 1 puff with a slow, deep inspiration to the count of 10, like. One watermelon, 2 watermelon, that kind of slow, not 1, 2, 3, 4, 5, and then another puff, and after they should hold their breath for about 10 seconds after they take the deep breath in.
Okay, good.
And
did you find all kinds of advice?
Yes.
And one thing we see often, Shirley, is sometimes when they are supposed to do 2 puffs, they put 2 puffs in the chamber. So make sure they don't do that. Yeah. 1 puff at a time.
Right. That's what I was having them do. But I just wanted to check with the experts here. And how do you feel, since we don't have a lot of data, and people tend to do this, about increasing the dose in the yellow zone? You were talking about this before, when somebody falls into the yellow zone, increasing the dose of steroids.
Yeah, actually 2 weeks ago I was in DC for our in-person Asthma Net meeting, and the data that is available right now doesn't show that it actually works when they double the dose of inhaled corticosteroids. So that is why we are actually designing this clinical trial to show that it doesn't work, or at least we think it's not going to work based on the evidence that is available right now. But then we're also testing to see if we increase the dose of inhaled corticosteroid 4 times of what is the daily dose, would that make a difference or not? But that is, we actually designed a protocol, and that was completed and was sent to protocol review committee at NIH for the final review. We're hoping we can actually do that study, and even if it's going to have a negative result, that would put to the end to something that we all sometimes do, but it may not be effective.
Okay, that's great. That's great. So right now, what would people recommend before the data's in?
We don't recommend that in our clinic, right, Francine? We do not recommend increasing the dose of inhaled corticosteroids. We just tell the patients to start using their albuterol more frequently, and if they use it frequently, as we explained to them in the action plan, then they start their prednisone.
Okay. So kind of the general guideline I give folks is if they're needing their albuterol every 4 to 6 hours consistently for more than about a day, and things aren't getting better, to start the prednisone.
Yeah, okay. Now, let me ask you about the data about the prednisone, too, because, Hengameh, you made a nice comment about more than 2 bursts of prednisone have an effect.
Correct.
And that was from CAMP?
That's what we learned. Yes, that's what we learned from CAMP.
And how big effect is it?
Yeah, it was only in the, we were measuring the bone mineral density, and that's where we saw a little bit of an effect. But it is just because we were using that bone mineral density as a measure of systemic effect of budesonide, and that's where we saw the effect.
And what are you not on the HPA axis?
There was no effect on HPA axis.
We
measured urine cortisol, and we also did the whole cortisone injection, and we did not see any effect on HPA axis. We also looked at the eye effects, all of these big inhaled corticosteroids effect. There was also no effect at the end of the treatment phase, as well as the follow-up.
Okay, good. And how? So, what are you currently recommending? Both. In your clinic for bursts of prednisone? How much and how long?
Well, generally we say 1 milligram per kilogram per dose twice a day, or 2 milligrams per kilogram once a day for 5 days. Certainly, especially patients who I've known for a while and are pretty on top of things, I tell them that, after 3 days, if they're much, much better, they can stop there. I think the guidelines say anywhere from 1 to 2 milligrams per kilogram per day.
5 to 7 days.
For 5 to 7 days. But yeah.
That's another area actually that we really don't have the right. We don't know what is the standard. Everybody is using in different ways. 5 to 7 days, 3 days, tapering, not tapering, 1 mg per kg, 2 mg per kg. For the network trials, we have come up with a standard dosing, and that is 2 mg per kg for 2 days, and then followed by 1 mg per kg for another 2 days. That's how we do it, but that was just a way to standardize management of exacerbations. So when we want to pull all the data together, we have just one way of managing these.
So you're going to do 2 mg per kg for 2 days, and then 1 milligram per kilogram for 1 day or 2 days?
2 more days. Total of 4 days.
2 more days, so 4 days.
Correct. This is how the network, has designed management. But this is not what we use in the clinic. Clinic is 1 to 2 mg per kg, once or twice per day for 5 to 7 days.
Right. But I think we all agree that you'd like to stop it if you could. Yeah.
Yeah, definitely.
And you don't taper. You don't taper, Francine, right, in clinic?
I think to be honest, I haven't ever looked up the literature to be sure, but I was always told that if it was less than 14 days, you did not need to taper.
Correct.
Yes, that's what I always, but I just didn't know if there was anything new.
No.
So thank you. That was terrific. Thank you, and
No
thank
problem.
you for letting me pick your brain. Brains.
Thank you.
Thank you.
This is Michael Lentz from ABQ.
Yes? Hi.
I have off-labeled and to save the use of oral prednisone increased their inhaled corticosteroids. And I knew that was never, a protocol, but it seems to have helped. And I don't have the right dose. Maybe it gives the parents something to do with increasing the albuterol. I would love to see a recipe to be able to do that, but the biggest disadvantage or the biggest problem and roadblock with this is the cost of inhaled corticosteroids. So even if you went through the studies and you doubled or quadrupled the inhaled steroids for 4 days, it would turn kids around. It's still going to be a big block because of the cost. I mean, these out-of-pocket steroids at the lowest dose cost $120 a month. Co-pays are $40 a month. So just a comment that I'd love to see it happen. I'd love to see a recipe, but I'd like to see the drug companies drop these prices.
Definitely.
Excellent point.
Definitely.
Excellent point.
Any other questions or comments?
So mention we have a case.
Is Gina Waymeyer on? She was going to present a case today.
She's in my office.
Can you hear me over here?
Yeah.
Okay. Can you hear me now?
Yes, I can hear you.
Oh, okay. Let me see if I can put my phone back on to speaker now.
Okay.
Let me see if I can do it that way. Okay. Okay, so for some reason I can't get you on my speakerphone, but I can get you on my handset.
Oh, okay.
Okay, so can everybody hear me or just you?
I think if we can hear you, everybody should be able to hear you. If you can't hear Dr. Waymeyer, would you please let us know?
Michael, can you hear me?
Yeah, I can hear you loud.
Okay, all right. So I'm in my office now. So, yeah, are you ready for me to present?
Sure.
Okay, so I have kind of a typical kid like the one I presented last time. This is a 7-year-old, and they come in today with their grandpa. And this is kind of the person that mostly takes care of them, but it's, I guess you would consider it the primary care provider, but